active motions in one fell swoop. So for flexion and extension, remind me, what cardinal plane are we in? Sagittal plane. How does the sagittal plane cut the body? Into a right and a left half. So there's my goniometer in the sagittal plane. So what I'm going to do is I'm going to have RJ stand up nice and tall with his arms relaxed to start with. I'm going to find the acromion because that's an easy place to start. And then remember, there's only about 1.1 centimeters between the acromion and the humerus. So my greater tubercle is going to be directly under it, and it's going to feel kind of rough to the touch. Now, if you have somebody who has really beefy deltoids, you're going to have to push a little bit. If you have somebody who has more of a slender build, you shouldn't have to push very hard to feel that rough surface. So that's my greater tubercle, and that's going to be where my fulcrum goes for this measurement. My stationary arm is just going to be either perpendicular to the floor or the ceiling. I like to use the floor because then I can kind of also follow the torso a little bit if I need to, especially in standing if the patient does happen to cheat it a little bit. In supine, the table knocks that out, so that's not a huge concern there. And then my moving arm is going to follow the shaft of the humerus all the way down to the lateral epicondyle. So RJ, what I want you to do is stand up as tall as you can for me. Grab a stool here just so I'm a little bit more eye level. There we go. And what I'm going to have you do when you're ready is just reach your arm forward and up in space as high as you can. Try not to let your shoulder come up by your ear. Try and keep some space there, and try not to extend your back. Just try and keep your back nice and straight, okay? All right, whenever you're ready, go ahead, reach your arm forward and up as high as you can go. All right, and RJ, you are at about 140 degrees of active shoulder flexion. What's normal? 180. And how much of that came from the glenohumeral joint based on the math we did earlier? Remember, it's 2 to 1. So divide 140 by 3, and then multiply that by 2. That's how much came from the glenohumeral joint. Good. So for extension, all of my landmarks are exactly the same, but I cue him to reach backwards. And if I'm doing this standing, I again want to make sure my patient is standing up nice and tall, that they're not leaning forward to try and get their arm back. Again, when we do it passively on the table will stop it, so I don't have to worry about that too much. This is just how I do it in the clinic for efficiency. So RJ, when you're ready, go ahead and reach your arm straight backwards for me. And RJ, that is about 45 degrees. What's normal? 60 or 70, or actually that seems kind of low for 50. I learned 60, and I thought some books said 70, but maybe I misremember that from the textbook. Extension's not something I measure a ton of. Most people have pretty decent extension. It's more so overhead movements and rotation that's most limited. All right, so then for abduction, I'll come in front of the patient, right? Because now I'm in the frontal plane. So I'm going to use the AC joint for my fulcrum. So I'm going to palpate that. So if I go down over the coracoid, that's too far. You can also palpate from the side and then come forward to the most anterior spot on that acromion. So that's going to be my fulcrum. My stationary arm is just going to be straight up and down with the ground, or when we're on the table, I'm just going to be parallel to the sternum. So I can palpate over the sternum and just make sure that I'm keeping those two items parallel. And then moving arm is just going to follow the shaft of the humerus all the way up onto the medial epicondyle. So what that looks like is RJ, I want you to stand up nice and tall. With your thumb pointing out, I want you to reach your arm out to the side and up overhead like you're making a snow angel for me. Go ahead whenever you're ready. And I'm going to use the goniometer to make sure he doesn't come forward in space and he's staying truly to the side. So there's his medial epicondyle there, right over the acromion, parallel with the sternum. And you are at about 117 degrees. What's normal? 180. So he's got a little bit of a tight shoulder. He's going to be interesting to see what happens when we get him on the table and do some passive measurements. All right, this is interesting. This is good. All right, now for measuring active range of motion, there's a couple of things you can do. One thing that I'll do is you can measure it 2 ways. You can measure it with the arm in neutral or with the arm at 90. When we do passive motion measurements in just a moment, we're going to do it from a 90-degree abducted position. Now you can do it from down low, and that's what I will often do. The landmarks are still the same when you're using the goniometer though. So what you'll do is, RJ, you're gonna bend your elbow to about 90 degrees. The olecranon is gonna be the fulcrum. So if you imagine that, that vertical or longitudinal axis going all the way down through the shaft of the humerus, it's gonna come down the olecranon, right? So that's where my fulcrum's gonna be. And then my stationary arm is just gonna be a nice straight line going to the front. And my moving arm is gonna follow the forearm out to the side along the styloid process. So when you're ready, RJ, go ahead and keep your arm near your side. Don't chicken wing your arm. And I want you to reach your hand out away from your body as far as you can. There we go. Pretty good rotation there. And he is at about 85 and normal's 90. So his rotation is actually pretty good. Now, it's hard to do it this way though when we're doing internal rotation because you're gonna hit the stomach, right? Mm-hmm. So if he can get his hand comfortably over his stomach, I know he's got at least 60 degrees there. So what a lot of clinicians will do actively to keep it functional is, well, you absolutely can adduct, which is a little uncomfortable, especially if your patient has impingement symptoms. You can also ask them to reach their hand behind their back. If they can get their hand to about their sacrum, that's about 70 degrees or so. And then the higher they can walk their hand up their back, the more motion that is. And if they can touch the inferior angle of their scapula, that's normal. That's about 90. So RJ, yeah, go ahead and turn around. And when you're ready, I want you to bend your elbow and try and bring your hand to your low back. There you go. If that's easy, try and walk your hand up the middle of your back as high as you can. So yeah, he has plenty of internal rotation. That's a functional measurement. Mm-hmm. You'll also see some therapists do a similar functional measurement for external rotation. They'll have the patient bring their arm up and reach their hand down, so that externally rotates the shoulder. And if you can get to, I think it's like mid-thoracic region, then that's considered normal. If they can only get to cervical, that's a little bit limited. So RJ, let's try that. I want you to bring your arm up overhead so that your hand is on the back of your head, and then slowly make your hand down towards the middle of your mid-back as far as you can. So yeah, he's pretty good there. So sometimes you'll see therapists kind of cheat it, so they don't use a goniometer per se, but they measure, all right, what spinous process did they get to? So not a super common one in the textbook per se, but you might see this in the clinic. So I just wanted to make you aware that there are many ways where we can ask a patient. You can relax, RJ. There are many ways that you can ask a patient to demonstrate active motion in the shoulder, either with a goniometer or just functionally. How far can you reach? So there's some variety there that I just want you to generally be aware of. So when you get to the clinic, it's not like, whoa, I've never heard of this before. What the heck? So now that you guys have seen kind of like, okay, this is how I would actively measure this, or this is something that I could ask the patient to do that would show me generally how far they're able to move in these ways. Now let's get to the passive range of motion measurements that you guys are going to be demonstrating in lab and in clinic or in the skill comps. And I think this table is a little